Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And tonight, I'm really honored and really excited to be interviewing Dr. Chani Yondorf. Before I introduce Dr. Yondorf, I am going to mention, as I've been doing recently, that I love it when people suggest people for me to interview or topics. This was a topic suggested to me by a listener, so I'm very excited to be doing this. Please reach out to us if there's someone you want to hear speak or a topic or comments about these podcasts to health, HEALTH, at joma.org. Dr. Yondorf is an obstetrician and gynecologist at the Albert Einstein Medical Center of Philadelphia. She graduated summa cum laude from Yeshiva University with a bachelor's in biochemistry. She began her medical training at Albert Einstein Medicine in the Bronx, graduated with a distinction in reach. She then completed her residency training in Obstetrics and Gynecology at Einstein Medical Center at Philadelphia, where she has remained on faculty attending physician. Welcome, Dr. Yondorf. Thank you so much for doing this with me tonight.
Thank you for having me. I'm so excited.
I'm really excited too. So I want to talk about a couple of things. This is really the topic of periods and pelvic pain is vast. I don't even know if we're going to be able to do justice to a part of it, but I just want to mention some other talks I did related so that hopefully we'll cover everything in the combination. Does that make sense?
Yeah, absolutely. I think that, I got your little outline of what you wanted to accomplish today. And I said, oh boy, is she overzealous? I don't think we're going to be able to get to nearly half that stuff.
No.
But I agree. I think linking us to some of those other conversations that you've had previously will be helpful.
And it's okay to do part two if you'll let me.
Absolutely. Always happy to come back.
I was overwhelmed. I mean, truthfully, the things that you sent me, there's just so much to this. So consider this an introduction and possibly an introduction part one.
Perfect.
So the other talks I want to mention are Rivki Chudnoff, who's a pelvic floor PT, which is a huge help in these kind of conditions. We talked about pelvic pain and we talked about dyspareunia and vaginismus and stuff like that we are not going to get into here. I can take that off our plate a little bit. That talk was called Ladies, We Need to Talk. And I also did 2 interviews with Dr. Alyssa Hellman of the Confident Kala about preparing our daughters for marriage, and also after the chuppah was part 2. So that also covered some of those topics. So I think we can go straight into painful periods and pelvic pain. And I do think that they all overlap and interconnect. So I'd like to start with heavy and painful periods.
Okay, that sounds perfect.
Yes, thank you.
I think that painful periods is a great place to start because it definitely is an entity, while related and connected to, in general, chronic pelvic pain or pelvic pain in general. It really is its own separate entity with its own separate, workup and treatment, in general. And so it's definitely a great place to start. So I will tell you that when it comes to painful periods, there are kind of 2 different categories that it falls into. So there's primary dysmenorrhea. Dysmenorrhea is the medical term for painful periods. So there's primary dysmenorrhea and secondary dysmenorrhea. And so what that means, primary dysmenorrhea is where your periods are painful, and they're painful without any underlying pathology, meaning when you actually look at the uterus, the ovaries, and anything in the pelvis, you don't really find anything wrong. It's just that the periods themselves are painful in and of themselves. That's primary dysmenorrhea. And then there's secondary dysmenorrhea, and that's where the periods are painful, but they're painful for a reason. Like there's some sort of underlying pathology that's causing that that pain to happen with your periods. And I will say that primary dysmenorrhea is way more common than secondary dysmenorrhea. So most of the time when women suffer from painful periods, it's simply because the periods are painful. Why it is that some women have more painful periods than others, there's not really always a great reason for that. In general, it's related to prostaglandin production. So prostaglandins are chemicals in the body that are inflammatory in nature or lead to inflammation. And so prostaglandins, or inflammatory chemicals, are produced when a woman menstruates, and they're kind of produced from the lining of the uterus itself, and from the process of ovulation, and from the process of the lining shedding itself. These prostaglandins are produced, and what was found is that in women who have primary dysmenorrhea, meaning where their painfuls are way more painful than expected, those women have an overproduction of these prostaglandins. So there's some sort of inflammatory process going on while these women are menstruating. What kind of separates it from like pelvic pain in general is that these women don't have pain during the rest of the month. Their pain is only there when they're on their periods. It might start a day or two before their periods and last for the first couple of days of their periods. But when they're not on their periods, they're not in pain. And that's kind of the difference between pelvic pain, like chronic pelvic pain and other pelvic pain conditions, and dysmenorrhea. During the rest of the month, they're just fine.
Right. I'm curious, what is normal pain with periods and what defines dysmenorrhea, which would be abnormal, right? Because most people do get some pain with their periods.
Absolutely. And I think that what would really define it is like women who end up needing to miss school from their periods because they're in so much pain, or miss work from their periods, or if it's associated with like nausea and vomiting, and sometimes it can be associated with headaches. And so basically it kind of makes them like non-functional when they're on their periods. That, I think, is where you start to see the pathologic nature of the disease. Everybody, or I would say most people, have pain with their periods. And most of the time taking a Motrin here and there, will take care of it. And that, I don't think, is what we're talking about here. What we're talking about here is somebody who, can't get out of bed and misses work and misses school and is sick from their periods on a monthly basis.
Right, but that would still be, how do you tell the difference between primary and secondary? How do you know when there's an underlying abnormality?
Excellent. So, when you are suffering from these painful periods, you come to your doctor, and then what your doctor is going to do is they're going to mostly talk to you, get a little bit of a history from you. And there's a couple of different ways to know the difference. So primary dysmenorrhea is generally, well, let me back up a little bit and say, what is secondary dysmenorrhea? So secondary dysmenorrhea, we kind of mentioned, is where they have painful periods and there's some sort of pathology underlying. And what are the most common pathologies there are things called endometriosis, adenomyosis, and uterine fibroids. Those are the three most common causes of secondary dysmenorrhea. There are other more rare causes of that. So if a woman has a Mullerian anomaly where their outflow tract is not completely open, so when they're supposed to get their periods, no blood is exiting their body, that also can lead to secondary dysmenorrhea. That's a much less common, obviously. That's much more rare.
Are you talking about someone who has, say, like an imperfect hymen?
Yeah.
They're not even having bleeding. So that would be something where you would have actually no period to begin with, that you would say.
Well, you can have some bleeding. So imperfect hymen comes in all different varieties, right? So it could be completely blocked and then they'll have no bleeding. But if they just have some people have small little holes in their hymen. It's not totally open, but it's not totally blocked. So they might have some bleeding, but they might not have a lot of bleeding. And that's because it's kind of most of it's getting stuck. But I don't really want to talk about that right now because I think that's really very unusual. But the more common causes of secondary dysmenorrhea are endometriosis, adenomyosis, uterine fibroids. And so endometriosis is the most common cause of secondary dysmenorrhea, meaning if it's not primary, then most likely it's endometriosis. And what endometriosis is, it is so the uterus is kind of made up of two different parts. There's two different layers, right? So there's the thick muscle layer that is the majority of the uterus. And then there's the lining of the cavity of the uterus, right? Because our uterus is a muscle that houses an empty space. And, one day a baby grows in that space. But when the baby's not growing in that space has a lining in it, which is made up of a different material than the muscle layer of the uterus. And so that lining can sometimes find its way outside of the uterus onto different structures in the pelvis. So it can be on the outside of the uterus. It can be on the ovaries, on the bladder, on the bowel, just on the plain abdominal, like the inside of the abdominal cavity. It can make its way all the way up to your diaphragm, and even sometimes very rarely into your lungs. So this lining of the uterus can be found anywhere. And what happens when the lining of the uterus is not found where it's supposed to be is it's still uterine lining. So it still responds to the hormones going on in your body. So when you get your period and your bleeding is coming out through your vagina, you're also having bleeding on these other little endometriosis lesions. And so you'll have a little bit of bleeding on this lesion on your bladder or on your bowel or wherever it is that it finds itself. And that blood, remember, we talked about how that lining is made up of, or has within it prostaglandins, inflammatory chemicals in them. And so that leads to inflammation wherever you have these endometriosis lesions, which leads to significant pain. And so there are different ways to kind of find endometriosis or see when somebody comes to me and says, I have painful periods, there are different things that I can do to kind of evaluate for endometriosis. So starting off with a simple pelvic exam. Sometimes because of endometriosis, you have these lesions in different places. So I can see it or feel it on exam. See it is much less common because it's much less common to find it in the vaginal canal or, on the cervix. But feel it, you can certainly feel it sometimes because you have these lesions that insert themselves on what we call the uterosacral ligaments, which is the part of the uterus that attaches the uterus to the pelvic floor. So you can feel that on a pelvic exam. Or if they have endometriosis in their ovaries, that can sometimes lead to a big ovarian cyst full of this endometriosis. It's called an endometrioma. And when that cyst gets big enough, you can feel it on your pelvic exam. Sometimes because of this endometriosis, the uterus is kind of stuck in place. And so when I do my exam, like that uterus doesn't move around like I expect it to when I'm doing an exam. And so that's, one way that I would be able to see if there is endometriosis. I will say that there are many times where the pelvic exam for somebody with endometriosis is normal. And that is important. Just because your doctor doesn't feel something abnormal does not mean it's not there, because endometriosis is a pretty sneaky underlying disease.
Well, what percentage of the time would it be normal? And what percentage of the time would you pick it up on exam?
I'd say it's about 50-50, I think. Okay. Probably more like 40% of the time you'd pick it up on exam, 60% not on exam.
Probably operator dependent too, right?
Agreed. Yes. The more of these you see and the more of these you feel, the more sensitive you are to them, for sure. And then I also, many times the exam is normal. And, another way to evaluate for endometriosis is by ultrasound. And again, though, I will say that there are many times where ultrasound is normal as well. And so it can be a very frustrating disease, endometriosis, because everything looks and feels normal, but yet there really is something going on underneath. But other findings you might see on ultrasound, the most common finding to see is a big endometrioma, a big cyst on the ovary full of endometriosis. It's a pretty classic finding on ultrasound. So when it's there, they see the cyst and you can tell because it's pretty, it's got the same appearance every time. And so you can tell that it's endometriosis on ultrasound. So they'll see it and it's pretty blatantly endometriosis. Other times or other ways that you can see endometriosis on ultrasound is that sometimes you have what's called deep infiltrating endometriosis. That's where the endometriosis is behind the uterus and kind of makes the uterus and the bowel stick together. And in that situation, like during the ultrasound, they kind of move the uterus around and they see that the uterus doesn't move away from the bowel. It's all stuck together. And they can see that on ultrasound, obviously not with a static picture, but through the ultrasound, they're manipulating the uterus with their ultrasound probes, and they're seeing that things don't move around. So those are kind of the two classic findings on ultrasound.
And what percentage of the time would it be normal?
Many times ultrasound is normal, because again, the thing with endometriosis is that there's so many different, there's a wide variety of how extensive this disease can be, ranging from just a few little spots on your peritoneal cavity or just a few little spots inside your pelvis to totally destroying the anatomy that's there. And the funny thing about endometriosis is that how disastrous it actually looks does not correlate with how much pain somebody's in. And so, you can have somebody who has like 3 small spots and have excruciating pain, and you can have somebody whose pelvis is completely ablated and have no pain whatsoever, just found incidentally. So, it's so hard. It's kind of like if you find it on ultrasound, then it's there. If you don't find it on ultrasound, again, that doesn't tell me it's not there.
Right. What age does this happen at?
Most of the time, endometriosis happens a little bit like kind of the reproductive age. So more like 25 to 35-year-olds is more common than, initially. So adolescents, less common. In adolescent, it's more common to have just primary dysmenorrhea. That's the most common thing for adolescents. And then endometriosis, you start to see it more around like 25 to 35-year-olds. And again, it becomes less common to see it when they're postmenopausal. Mm-hmm. And then there was one other thing. Oh, the other thing I did want to mention about endometriosis that kind of makes it a little bit different from just primary dysmenorrhea is 2 more points. One is that with endometriosis, especially with the type that's kind of deep infiltrating endometriosis, you'll have some other symptoms as well. So it's not simply painful periods, but you might also have pain with sex. So obviously that's hard to tell for somebody who's not sexually active yet. But for women who are sexually active, they'll have pain with sex because, the nature of having like sexual intercourse, you will kind of come up against those endometriotic lesions, which will cause pain. So that's one thing that you won't find with primary dysmenorrhea with, not having any underlying pathology. And then the other thing you'll see with endometriosis that's a little bit different is that if the lesion is found on the bladder or if the lesion is found on the bowel, you'll have symptoms related to those organs. And so what that means is like, if you have lesions on your bladder, then, around the time of your period, you might notice that you have pain when you pee, or you're peeing more frequently, or you have urinary urgency, symptoms of a UTI. You might even notice that you're having bleeding with, blood in your urine during your period, because remember, those are uterine lining lesions that are found on your bladder, causing inflammation on your bladder and bleeding into your bladder. So you might notice those sort of things. And, if you have the lesions on your rectum or on your bowel, you'll notice pain with pooping. You might have diarrhea or constipation. You might have blood in your bowel movements because of endometriosis. So those are things you won't necessarily see with primary dysmenorrhea, but you would see them with endometriosis. So that's, another difference that you would find there.
But I want to go back a little to primary dysmenorrhea and ask how you treat it.
Great. So, it is basically, once you've kind of ruled out these other things as issues that would be causing it. So now the goal is to get somebody comfortable and functional during their periods. And so we know that the underlying cause of the dysmenorrhea is this increased inflammatory environment. And so the number one treatment for it is anti-inflammatory medications, most notably NSAIDs, or non-steroidal anti-inflammatory drugs. And those are things like ibuprofen, naproxen, Motrin, that sort of medication. The trick with those is that, a lot of people are like, oh, well, I use them and they're not helping me, so it's not working. The trick is that that there's a process going on, which is an extra inflammatory environment there. And so you need to kind of cut it off. So what that means is like a day or two before your period, you start taking those anti-inflammatory medications and you take them around the clock, whether or not you feel pain, through the first 3 days of your period. And that way you're kind of tamping down that inflammation from ever even starting. If you let that inflammation get up and roaring and then you try and calm it down with a pill or two here or there, you're never going to get it under control. And so that is where a lot of education comes into play. When somebody comes and they're just like, I give up, it's done. My periods are the worst. Nothing I do helps. You're kind of like, okay, let's take a step back. Let's kind of nip this in the bud. you get a regular period, a day or two before your period comes, start taking the naproxen. I personally like naproxen because it's a twice a day dosing versus something like ibuprofen, which can be a 3 or 4 times a day dosing, depending on what dosage you take. So naproxen is twice a day, which makes it easier, I think, for a lot of people to keep up with. And you just take it twice a day, starting 2 days before your period and through the first 3 days of your period. So that, is definitely something I strongly recommend for primary dysmenorrhea. And then the question becomes with or without, hormonal contraception. Mm-hmm. And so the hormonal contraception works in a different way than the NSAIDs, and they kind of complement each other very nicely. So the way that the hormonal contraceptions work, you can either use them. So in general, contraceptives, like the combined oral contraceptives, have 3 weeks of active pills, which have both estrogen and progesterone in them, and then 1 week of a sugar pill or a placebo pill, which is the week you get your period. So you can actually take it just like that and still get a period on combined oral contraceptives, or you can skip that last week and go straight to your next pack and skip your period. And actually taking them either way, both of those ways have been shown to decrease the pain that you get with your periods. And the reason is kind of twofold. So the first is that the estrogen in the pill kind of is there and it suppresses ovulation. So it stops your body from ovulating. The process of your ovary making an egg and releasing that egg ramps up the inflammatory environment in your pelvis. And so kind of stopping that process from happening helps to decrease how much inflammation is there. And then the progesterone that's in the oral contraceptive pill, that will make the lining of your uterus really, really thin and atrophic. And again, that lining is what's containing all that inflammatory media. And so if you don't have a lot of that there, then there's not a lot of inflammation there. And so kind of taking the two together, the oral contraceptives and the NSAIDs are first line treatment for primary dysmenorrhea.
Mm-hmm. And how do you treat endometriosis?
So funny enough, endometriosis is actually, you start off treating it exactly the same way. With endometriosis, a lot of times it responds the same as with primary dysmenorrhea because, again, you're decreasing that inflammatory environment, and you're also, the birth control pills work on those little spots of endometriosis the same way it works on the lining of your uterus. So it makes them really, really thin. A lot of times the progesterone that's in the birth control pills will cause those lesions to kind of atrophy and die off. And so, that is first line for endometriosis as well.
Mm-hmm. What is the relationship between endometriosis and fertility?
Great question. So endometriosis is associated with a decrease in fertility. So women who are struggling with infertility, it's funny that I think it's about 50% of women struggling with infertility are found to have endometriosis. And the reason why is there's kind of two different theories. None of them are 100% proven, but theory number one for how endometriosis is related to infertility, and this one is really more like seen and understood, is that when the endometriosis is really severe, it can lead to anatomic abnormalities, right? And so you can end up with so much scarring from all of this inflammation and all of these endometriosis lesions kind of making everything all stick together. And so you can block off the fallopian tubes. You can, and if you block the fallopian tubes, the sperm and the egg just have nowhere to meet. The egg never makes it into the fallopian tube. The sperm never meets the egg. You can't get pregnant just because it's all blocked up. So that's like way number one, that endometriosis impacts fertility. The second way that it does it is by creating this inflammatory environment in your pelvis. It's been shown, or it seems to have some sort of effect on sperm motility, on sperm's ability, like it kind of disables the sperm, all of this inflammation. And it also leads to what we call an inhospitable environment in the uterus as well. There's so much inflammation there that, that an embryo, if there is one, has a hard time kind of finding a happy home in there. So that one is not as well proven per se, but definitely thought to be part of why some endometriosis, when it's not as when you don't see so much adhesive disease, endometriosis itself can still lead to infertility. And that would be the reason behind that.
Can endometriosis be asymptomatic?
Absolutely. So endometriosis is asymptomatic in about I don't remember the percentage offhand, but many women are found to have endometriosis incidentally, either during laparoscopic procedures for other, reasons that they're having them done. What's interesting is that even though endometriosis, and this is why we don't truly know the prevalence of endometriosis within society, because so many people who have it are not getting diagnosed with it because they're asymptomatic from it. But what we do know is that women who suffer from pelvic pain, about 50% of them are found to have endometriosis, and women who suffer from infertility, about 50% are found to have endometriosis, and women who suffer from pelvic pain, about 70 to 80% are found to have endometriosis. So we definitely know that it is an entity that exists and causes these issues. We don't understand how it's there as well and is asymptomatic in so many women.
Right. I mean, there's nothing you can do about something that you have no indication you have, but I'm wondering if treating painful periods aggressively would be preventative at all?
So not really.
No.
Well, it hasn't. I mean, I know it's kind of that hopeful thing. So unfortunately, just using oral contraceptives or NSAIDs to treat painful periods and to treat endometriosis has not been shown to improve fertility.
But doesn't it decrease the inflammation?
Yes, but once you come off of those medications and you try to get pregnant, it doesn't necessarily make it any better, right? Because you can't get pregnant on an oral contraceptive.
Right. Are there other medications that are used for this?
There are other medications that are used for endometriosis for painful periods, but not for the infertility part of it. So the only thing that really helps with the infertility part of it, and this is also something that is very controversial about whether or not it helps, is surgery. So surgery for endometriosis, there's different options out there when it comes to surgery for endometriosis. Number one is when women are found to have an endometrioma, meaning that cyst full of endometriosis on their ovaries. So that has been shown to decrease ovulation in women. And so for women who are, struggling with infertility and have these endometriomas, removing them has been shown to improve their chances of getting pregnant. The flip side of it, though, is that endometriosis is very, very sticky, meaning it makes everything stick together. It's very hard to get off. And so doing the surgery, to remove the endometrioma from the ovary, while it's helpful for women to get pregnant, on the flip side, it also does sometimes decrease their ovarian reserve, meaning in order to get that full endometrioma out, a lot of times you're taking out good, healthy ovary as well, portions of it. So you're taking out some of those good, healthy eggs that are there too. And so you definitely don't want to be doing that type of a surgery over and over again. But if the lesion or, if the endometrioma is bigger than 5 centimeters, it's definitely recommended to go ahead and take that out, because there have been improvements in pregnancy rates after that.
Are there less invasive procedures than surgical removal?
For an endometrioma?
Mm-hmm.
Unfortunately, no, you can leave it there, especially if it's less than 5 centimeters, you can leave it there. But there's no other way to get rid of it. It doesn't necessarily go away on its own. No medicine makes it get less. There is another medicine for endometriosis, but this one, it does not help with fertility. It's basically GnRH agonist and GnRH antagonist. So GnRH is a hormone that is made by the brain that signals the ovary to start, making eggs and ovulating those eggs. And so what we can do is we can use GnRH agonist and antagonist to kind of shut the whole system down. So if we give that medication externally, we kind of overload the brain. And so the brain stops making it. And then there's no message going to your ovary to start, making eggs and ovulating it. And so what happens because of that, because your ovary is not ovulating or making any eggs, is the ovary's estrogen production goes down. And so this puts you into this almost like a menopausal state where you have a very low estrogen level. And so it kind of shuts the whole system off. And so estrogen is that hormone that makes that uterine lining build up. It increases inflammation. It kind of causes the lining to expand and proliferate. And so by shutting off that estrogen, you kind of stop that lining from proliferating altogether. But it does kind of put you into what we call like a menopausal state. So some women will have some hot flashes because of that. There can be, if you're on it for a long term, can be bone loss on it. And so, sometimes we can kind of mitigate those side effects by using progesterone, which is a hormone that kind of helps prevent women from feeling that way, without, adding back that estrogen in there. And so that is an option for women who try the birth control pills and try the NSAIDs and don't want surgery. This is definitely another option. So the mainstay that's been around forever is Lupron. That's a GnRH agonist. That is an injection medication that you get. The downside of that is, because it's an agonist, meaning it gives you a lot, like it increases the GnRH that's there before you have everything shut down. Everything kind of ramps up a little bit for the first 2 weeks. And so with that medicine, the first 2 weeks are a little bit miserable. And then you have like relief after that for 3 months, really, for 6 months, you can keep that going. There's a newer medication that's out on the market that is a GnRH antagonist. So meaning it blocks GnRH altogether. And so that one, you don't have that big surge of the hormones in the beginning. You just kind of stops it from the beginning. The nice thing is it is an oral medicine versus an injection. So the Lupron, once you get it, you get it. Can't take it out of you. You're in it for the ride and hopefully it works. With the oral one, you can start it. And if you're seeing it's not working for you and you're feeling sick on it, you can always stop it. But that is a much newer medication that's out on the market.
So what else is out there? Because it sounds like, this is a difficult problem without easy solutions.
And it is a very difficult problem without easy solutions. There are other things out there that are not medications. So, exercise has been shown to help. Heating packs has been shown to help. There's not great data on things like acupuncture, but again, those things don't necessarily hurt. So it might be worth helping. And then here's kind of where I'm going to put in my plug for some of those previous discussions you had, but pelvic floor physical therapy is huge here. And so, obviously it's not going to fix the problem, right? Having physical therapy is not going to, take away those endometriotic lesions. It's not going to fix the problem, but what it will do is teach you different relaxation techniques and different stretches that you can do to help, that those muscles that are all in your pelvis are all sitting there and feeling the effect of that inflammation. And so going for some pelvic floor PT can help combat that, and help get you through it as well.
Mm-hmm, mm-hmm. No, that's really good to know. I want to move on to adenomyosis. I said it right?
Yes. Yeah. So adenomyosis is it's kind of, you can think of it like a subset of endometriosis. And so endometriosis is where the lining of the uterus is found outside of the uterus. Adenomyosis is a different condition. It's where the lining of the uterus is found within the walls of the uterus, within the muscle layer of the uterus. So the way I like to explain it to people is that the walls of the uterus or that muscle layer kind of act like a sponge. And so, whenever you get your period, right, some of that lining sheds itself into the vagina, comes out of your body, but some of it kind of gets soaked up into the walls of your uterus. And then what happens with subsequent periods is that every time you have like the hormones, impacting your endometrial lining, they're also impacting those bits and pieces of endometrium that are within the walls of your uterus. And so what you'll wind up with is heavier periods, much more painful periods. Your uterus can get a little bit enlarged and globular, kind of feels like a big balloon, because the walls get softer because they're kind of full of all of this lining tissue that shouldn't be there. So that's adenomyosis. Adenomyosis is a little bit more difficult I shouldn't say more difficult to treat, but meaning the only absolute treatment for adenomyosis is removal of the uterus. That is, the only absolute treatment for it. But there are definitely ways to make you or to help somebody get through, their reproductive years without suffering tremendously. And those ways are very similar to some of the stuff for endometriosis. Birth control pills to kind of tamp things down. And one other thing I didn't mention with endometriosis, but it is also very helpful, is an IUD. So if you're not looking for childbearing right now, if you're not looking to get pregnant right now, an IUD can be very helpful as well. And an IUD can be very helpful for adenomyosis too.
Mm-hmm. How do you diagnose adenomyosis?
So again, it is, when you do a pelvic exam, you can feel that the uterus feels a little bit bigger, feels a little bit boggier. And there's also different, signs on ultrasound. There's pretty classic signs on ultrasound where the uterus looks bigger. They can see kind of how the walls are a little bit boggy. They can see signs of the lining of the uterus within the walls of the uterus. The only way to definitively diagnose it is by taking out the uterus, cutting it up, and looking at the walls and seeing that there's lining tissue inside. So that's another reason why, the incidence of adenomyosis is not 100% known, because some people don't get their uteruses taken out. So,
right. So I'm wondering how accurate physical exam and visualization is.
Yeah. So, visualization, you can't necessarily see it just by looking at it like laparoscopically necessarily, but how accurate is it? Physical exam, probably less accurate, right? You can feel a big uterus, but how do you know it's truly adenomyosis? The ultrasound, it does have a pretty classic look to it. So, depending on how good the radiologist is and how much they see adenomyosis will also, influence it. But, there are pretty classic signs for it.
But I'm wondering, is that just the most extreme, obvious cases? Like, it's probably a spectrum, right?
For sure, it's a spectrum. But again, I don't think that adenomyosis becomes clinically significant until it's something that you can, really see on ultrasound. So that's kind of global adenomyosis is what I'm talking about. There are other things called focal adenomyomas, which is where, you'll have that lining soak into the wall, but only in a certain spot. And so it'll kind of just look like a different ball of, fuzziness in the lining of the uterus. And that, can be confused with a fibroid. A fibroid is a benign growth in the uterus. It's a benign growth of uterine muscle cells. And the adenomyosis is where you have the lining of the uterus in the muscle. And so the difference is that a fibroid is pretty separate from the uterus. So it's pretty clearly demarcated. You can see where it starts and stops. The adenomyosis kind of is it blends in almost to the uterus, and then you kind of see this space that's a little different.
Right.
And when you
explained, I'm sorry, I interrupted. I think you explained it before we started with the fibroid really has a shell. It has a capsule.
Exactly. And that's where I was.
Does not. I'm sorry.
Yeah. And that's where I was going. That's exactly where I was going. But the thing is, you can't really see that until you do surgery, right? So I can't necessarily see that on ultrasound, but when I'm in the operating room and I'm, doing surgery, I can see you can see the shell of the fibroid. You can pop that fibroid out. It comes out easily. It's very separate from the wall of the uterus. When there's an adenomyoma or adenomyosis, it just, again, it feels like a big mushy sponge. And I can't always tell where it starts and stops because there is no clear demarcation or delineation there.
But can it be surgically removed?
So I think there's some experimental procedures out there that haven't necessarily been proven to work and aren't used very commonly. So it's hard to really say if they work or don't work because not enough people have gotten them. There are procedures like wedge procedures where you can kind of wedge out the portions of adenomyosis that are there. Whether or not that actually works to improve pain or works to improve, fertility or bleeding or all of that stuff is not really known because they're not very commonly performed. Most of the time, if somebody has adenomyosis and is bothered by it, the surgical procedure performed is a hysterectomy. Mm-hmm. If you're going to go with surgery.
I read somewhere something about risks with later pregnancies after having this procedure. So if you could elaborate, great.
Of course. So anytime you have any sort of surgery on the walls of the uterus, on the muscle layer of the uterus, you are leading to, or you're putting yourself at risk for dangerous pregnancy outcomes. And so the risk is that when you kind of cut a piece of the muscle of the uterus out, when the placenta comes, and there's really two risks. The first is, when the placenta implants into the uterus. So normally there's a nice layer that separates the lining of the uterus from the muscle of the uterus. And the placenta knows when it's kind of digging itself into the lining of the uterus, it knows to stop. because it has that basement layer and it knows not to go past it. But when you've had surgery that messes with that, the placenta itself can kind of invade the walls of the uterus, and it becomes almost like a tumor where it can invade the walls of the uterus. It can invade through into organs around that area. So sometimes the placenta can invade through into the bladder even. So that's it's called like a placenta accreta, which is where, and that is a pretty dangerous condition. It can lead, to hemorrhage. It can lead to, the baby not getting enough nutrients. It can lead to the baby needing to be delivered early. And most of the time, if that happens, then when it comes to the delivery, there's really no way to separate the placenta from the uterus. And so you have to do what's called a cesarean hysterectomy, meaning at the time of the cesarean delivery, you have to remove the whole uterus as well, because there's no way to separate that placenta from the wall of the uterus, which can be, so it can be a pretty morbid procedure. So that's one risk of doing a surgery like this, is that you have that potential for abnormal placentation. And then the second risk is that, so when it comes to labor, labor is contraction. So the muscle wall of the uterus will have to contract in order to expel the baby. And so when that muscle has had a big chunk cut out of it and is now sewn together, that area is definitely not as strong as the original muscle once was. And so when it contracts, that muscle, that area can kind of pop open. It's called a uterine rupture. And that can be pretty devastating both for mom and baby, because of how quickly that bleeds and how quickly the baby, is without oxygen. So I would imagine if you have a procedure like that, the recommendation would be to deliver you by cesarean section, not to let you labor, and to deliver you at 36 or 37 weeks. So a little bit premature at the very earliest part of term, because we really would want to prevent any sort of contractions from happening.
So how do you treat adenomyosis in someone who still is having children?
So again, the treatment is similar to our treatment for primary dysmenorrhea and endometriosis. It is, NSAIDs and birth control pills and IUDs. Adenomyosis doesn't have as much of a link to infertility as endometriosis does. And I think that's where I just want to make that clarification. So adenomyosis more commonly will present with heavy, painful periods, not necessarily infertility. So most of the time, if a woman is trying to get pregnant, you can kind of manage her heavy, painful periods with the NSAID alone and not add on the hormonal contraceptives. If a woman's not actively trying to have a baby, but doesn't yet want to remove her uterus, the hormonal contraceptives along with the NSAIDs help her get through her periods, while waiting for her next, baby.
Right. Now, you would say that both endometriosis and adenomyosis would be cyclic pelvic pain syndromes, right? Would that be true?
For the most part, that's true. But, adenomyosis more so cyclic. One of the distinctions of the endometriosis secondary dysmenorrhea versus the primary dysmenorrhea is that sometimes endometriosis can also prevent with pelvic pain throughout the month as well. So endometriosis is a little bit more of, an enigma here. Again, it's commonly painful periods, pain with intercourse, pain with other organs, depending on where it is, but it can be pelvic pain just throughout the month as well.
Right, because I did want to talk, I know we're running out of time, but I really want to talk about pelvic pain, a lot.
Oh my, yes. Pelvic pain is a humongous topic. We can try and scratch the surface, or we can definitely come back. But yeah, it's a huge topic, pelvic pain.
Yeah. Let's at least do a superficial introduction to pelvic pain.
Okay.
And it's not necessarily cyclic, which could include endometriosis.
Absolutely. So pelvic pain can happen for, again, a whole variety of reasons. And I know that, a lot of times and many times it's related to our GYN organs, but let's not forget there are other organs in our pelvis as well. And so pelvic pain can happen because of things like, inflammatory bowel disease or irritable bowel syndrome or interstitial cystitis, which is like painful bladder syndrome. There's also something called myofascial pelvic pain, which is pelvic pain related to the muscles and, pelvic floor muscle dysfunction, which also can lead to pelvic pain. And so pelvic pain can be caused by, a whole variety of different things. And kind of, one of the biggest things that I, like to tell my patients when they come to see me and they're, struggling with pelvic pain is this process is a process that, didn't happen overnight, right? So you didn't develop this pain. You didn't wake up one morning and have pain and boom, and that was it, right? This process took time to develop. And so it takes time to figure out what exactly is going on, and it takes time to treat it. And there's no magic pill or magic medicine or magic surgery or magic anything that's going to make this pain just, go away. It will take a number of visits to your OBGYN. It will take some visits to a GI doctor and a, urologist. And this is yet another plug for pelvic floor PT because I think PT. Yes, because pelvic floor PT is, absolutely necessary in treating pelvic pain. It doesn't go away by itself. It doesn't go away with medicine alone. You need, you need that physical therapist there to help your pelvic floor get back to itself. Because even if the cause of your pelvic pain is not your pelvic floor muscles, those pelvic floor muscles have suffered a beating from everything else going on there. And so you need to teach them how to kind of, get back to themselves and not be always in pain.
Right. What's a basic workup for pelvic pain? Because, I think that, people want to find out what's wrong with me. And, I'm a general pediatrician. I feel like my correlate might be IBS as a pediatrician, right? The patient comes in, they're in pain and they want labs and they want, tests. But a lot of times we do them and they're still going to be normal and yet the pain persists. So I'm wondering if this is like your correlate.
Yeah. And the way I like to say it, so yeah, sure. It definitely can be that, right? So when somebody comes to me with pelvic pain, the first thing we do is we cross our T's and dot our I's. We look for every possible true, visible pathology there that can cause pelvic pain. So we look at the uterus to see, is there, are there fibroids in the uterus? Is there adenomyosis? Is there endometriosis? We look at the fallopian tubes. Are they blocked for whatever reason? We look at, we look for infection, right? So, sexually transmitted infections can cause pelvic pain. Pelvic inflammatory disease can cause pelvic pain. So we have to look for infections as well as a cause of that. We look for ovarian masses or ovarian cysts. Those can also be causes of pelvic pain. We again work hand in hand with our urologists and our GI docs to look for things. Constipation can cause pelvic pain. IBD, IBS, just like you said. We have urologists will sometimes do what we call a cystoscopy, where they look inside the bladder to look for any reasons in the bladder that can have pelvic pain. And, if we find a reason, then, wonderful. We find a reason and we treat that reason. But a lot of times what happens is there's like some sort of initial insult that happens, and then that insult goes away and it's treated and it's done. And because that insult happened, that leads to kind of a rewiring of the nerves and muscles in your pelvic floor or your pelvis in general, right? And so what happens is you no longer have pathology there, but your nerves have been shot. And now anything really, they're kind of standing on edge and they're really tense, and any tiny little thing will set them off and make you feel like there's pain there. And so things like, having a UTI just once, and then all of a sudden your bladder, all the nerves that feed your bladder are kind of like, oh my God, I have another UTI, when really you don't. Your nerves are having trouble figuring that out. And that is why pelvic pain is so hard to treat. And so, different things that we can do sometimes to help when it's kind of what we call like central somatization, right? So, your nervous system now is on high alert. And so a lot of medicines used for nerve pain can be helpful. Some medicines that are, classically used for depression and anxiety can be helpful, mostly because they work on helping your nerves refigure themselves and, how to respond to normal stimuli without feeling so much pain. So it's not that, you don't have pain. You right. Certainly have pain.
It's real.
And that pain is real. It is 100% real. The problem is that inciting event is no longer there. And so now we kind of have to work with your nervous system to help it relearn how to handle just normal life.
Right. I interviewed a pediatric IBS specialist. And because again, this is correlate in my mind, I see it as very similar. And she said it's like a car alarm that's oversensitive. Mm-hmm. And you just go past the car and it goes off. Nobody's breaking in.
Exactly.
The alarm. That pain is that alarm going off. It's real.
Exactly.
To be dealt with, but you might not find that abnormal lab or that abnormal exam finding.
Exactly. That 100% true. And that's why I think a multimodal approach to the pain is critical. It's the only way to make it work, because there is not one thing that is going to fix it, because now you just have to figure out how to retrain your body entirely. So whether it's, using, the gabapentin, the Lyrica, the nerve medications, or using the SSRIs, the SNRIs, the depression medicines, going for pelvic floor physical therapy, seeing, doing even cognitive behavioral therapy and learning different coping mechanisms to help, handle these new stressors that you're going through. All of it goes hand in hand. And again, I cannot stress enough, it is not going to go away in one session, right? It took years to form, and it's going to take time to go away. And just knowing that you have a team behind you and a team helping you, just utilize us. We're here for you.
Right. I think it's also important to talk about the mind-body connection in that it goes both ways, because I think there's a tremendous sensitivity to being, to feeling like somebody thinks this is all in your head, right? So then there is a higher incidence of anxiety, depression, right? Trauma, history of trauma, prior history of abuse in cases of pelvic pain, right?
Yeah, absolutely. And I mean, I think this is where people sometimes, get very upset, right? So if somebody comes in and talks about pelvic pain, or comes to complain of pelvic pain, and, my questions I have a lot of questions that I ask, but some of them are like, are you safe at home? Are you safe in your relationship? Have you ever, been the victim of verbal abuse, physical abuse, sexual abuse, right? And people get really mad, and they're kind of like, oh, so you think this is in my head because I was once abused as a kid? And you're like, no, I don't. But I think that our bodies and our minds are so strongly connected, and it goes both ways, right? So, Loa knew some people are victims of abuse, and as a result, your body has, kind of, again, become hypersensitive, and all of your pain stimuli are really out of whack because of that abuse. But also, even if you weren't abused, having pain all the time can lead to depression, and then depression can lead to worsening pain. And it's kind of like, what came first, the chicken or the egg? And I'm not sure I'll ever know, but both have to be treated in order to make it better.
Right. And having that mental health component to it doesn't invalidate the pain.
100%. 100% it doesn't.
But it is super sensitive.
Yeah. And I think, that it's a lot of times why, when it comes to pelvic pain, these patients have to come and see a doctor over and over again. And I often won't bring it up necessarily, I'll obviously screen for abuse because I think that's important, but I won't necessarily bring up like the mental health component on the first visit, because I think that, you want to develop a sense, you want your patient to know that that you validate them, and you do validate them, but sometimes some of those questions can come off a little wrong. And so oftentimes, like, I'll start with the physical, we'll start with the real, and then, the next visit, the third visit, the fourth visit, like we start to bring up like, hey, do you think that this might be related to like other stuff going on in your life? Are you undergoing a bad divorce right now? Is your kid really sick? And you're struggling with that. Like, are there other things in your lives? Because, our brains and our bodies and our emotions are very strongly connected. And so, again, I won't necessarily bring that up, day one, because I think that does lead to some sense of distrust, unfortunately. I can't wait for the world to be more open and accepting of mental health and the connection. But until that happens, you have to kind of formulate trust first with your patients.
It's interesting that you say that, because in the IBS lecture, she said that there's a golden 5 minutes where you need to start from the very beginning. And I do find this with IBS, that if you don't from the very beginning talk about the mind-body connection, you can easily go on an endless quest for the diagnosis. Right?
Yeah. I mean, I think that I hear that. That's definitely a valid point. But I think you have to read your patient, and I think you have to, see what's going on. And I don't know how it goes with IBS, but I do know that with pelvic stuff, people get very sensitive about it. unfortunately had many patients get very angry about, something like this. And I kind of want them to feel like not poo-pooing their problem. And then once they are like, oh no, she's serious, she's really looking for something. And then when there's, not something there, you're kind of like, okay, something must have happened, or there's something else going on. Let's look a little deeper, and that they have already, they already feel comfortable. Like, I'm not just throwing this, oh, it's just your depression,
But I look at it differently. I look at it that you should never think that you've ruled everything out, because, for example, we talked about how endometriosis can be asymptomatic, how the exam is not perfect. For adenomyosis also, unless you're taking out that uterus, you may not know that it's there. So these are diagnoses that I think are easily missed. And I think there's a sensitivity to, if I tell you that I have this trauma, then you're going to think it is purely psychological. You're not going to find the cause of my problem. It's not either or, it can be both.
Absolutely.
I think we got better at saying from the very beginning, I am not going to give up. I am here with you for the journey. I trust your gut that we're going to find what this is. But at the same time, we're going to deal with your mental health because they're interconnected.
Yeah. Yeah. I mean, I think that, there's 100 ways to skin a cat. And, I think you have to kind of read your patient, see what works, see where they are. And, I think that either way.
Yeah. And you also have to have that relationship, right? And not everybody's equally open. Some people are right away into that brain-body connection. We talk a lot about the brain-gut connection. So I'm dealing with this all the time with IBS. It's not quite the same thing with what you're dealing with, right?
Absolutely.
It's different. But I think those are important conversations to have, because pelvic pain is super, super complex. And I don't think that we can get to the bottom of it. We talked a little bit about the treatments. We didn't talk at all about any procedure treatments for pelvic pain. Do you want to go into that at all? Robust is the spoiler alert.
What'd you say?
Not super robust, which is the spoiler alert.
Correct. There's not a lot out there for chronic pelvic pain when it comes to procedures. There's a tibial nerve stimulation. So that is something that some physical therapists or some pain specialists will do. Again, sometimes it works, sometimes it doesn't. There's not great information on it. There's these procedures called neurectomies. So where, you kind of the presacral neurectomies, where you kind of interrupt that nerve from, transmitting the signal. And, again, there's not good information that works at all, which is why it's not really discussed so much. It's not really used so much. One procedure that I will say has been shown to be somewhat helpful is trigger point injections. Mm-hmm. So, what's funny about it is that some people will do trigger point injections, even just with saline, and just the injection itself, and that trigger point can sometimes help relieve some of that pain. There are some newer procedures out there, which is botulism or Botox injections. Botox injections into the pelvic floor muscles, and that has been shown to help with some chronic pelvic pain. These are procedures that generally your general gynecologist is not going to do. This is where you kind of jump into that realm of going to see a pelvic pain specialist. And they're out there. And they're oftentimes the ones doing those procedures.
Mm-hmm. Well, that's good to know. And again, we're not here to give medical advice. This is purely for informational purposes, as the disclaimer in the beginning says. But I always like to emphasize that you are your own best advocate, right?
Absolutely.
And it's really important to trust your gut and to keep looking if you feel like something's been missed, right? Because I can see how there could be a diagnostic quest, which a patient may feel has been ended early because they're being told, oh, well, you had this trauma or you have anxiety. And, they are saying it is all in your head, which is wrong because the pain is real. And there may be something like adenomyosis, which it sounds like it can easily be missed, or endometriosis.
Absolutely. No, 100%. And I couldn't agree with that more. You have to be able to trust your doctor and feel comfortable with your doctor. And, if you don't, there are plenty more out there. So don't feel like you're married to that one, physician you go to. If you're feeling like you're not being heard, don't hesitate to get out there, because there are so many good doctors out there. You just got to find the right one that clicks with you.
That's true. And that is a great way to end. Although I think we're going to have to come back and deal with all the topics. We go a little deeper on some, but I want to thank you so much for doing this with me. I really appreciate it.
Oh, you are so welcome. It was really fun. I'm glad you asked.
It was. And thank you so much. I really appreciate it.
All right. Have a great night.
So.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.